I guess this is the perfect time then for me to welcome you to this Latin American Regional Discussion Group, the first of our series for 2024. So I am Nicola. I will be your host for today. So if you have any questions, please write to me in the chat. I am the Chief Executive of the International CML Foundation, and this is one of a suite of our programs which is really looking to improve the outcomes for people with CML around the world. And this is part of our educational platform. And many of you who have joined us today have been part of our clinical preceptorship programs. You have seen our Knowledge Centre, which is on the ICMLF website. And I hope you will also join us in our next conversation webinar, which will be the highlights of Ehab next week on the 3rd of July. The other part of the ICMLF, which again, many of you will be aware of and some even participate in, is the power of the International Foundation in our global research programs, both our Genomics Alliance, our Treatment-Free Remission Alliance. We have pediatric treatment in low and middle income countries, a case series underway, and there are many more opportunities to be part of the ICMLF as part of our global network of clinicians and physicians and researchers who work with us and help us improve outcomes for people with CML all around the world. I would like to take the opportunity to thank Novartis, who are supporting these particular regional discussion groups this year. And so we really appreciate their support. And with that, I'm now going to hand over for today for our debate to Arlene, who is going to be the moderator for today. And again, thank you for joining us. And I look forward to a really interesting debate and conversation.
Hi, welcome everyone. So nice to see so many familiar names and faces in the list there, and some new ones too. Great to see you here. So welcome to our first debate-style discussion in the ICMLF series, where the proposition is dose reduction is the best pathway to treatment-free remission. This is an important topic. It's an active area of debate between practitioners. So we thought we'd do just that. We'd have a debate, but also have a bit of fun in our approach to discussing such an important topic. So we have pitted some of our very best minds against each other. Let's see how they go. So firstly, it's my pleasure to introduce the team speaking in favor of the proposition. Our regional expert favoring dose reduction as the best pathway to TFR is Dr. Virginia Abello Polo from Colombia. She's a great physician and researcher, an ICMLF Key Discussions alumni, and a member of the Foundation's Latin America Steering Group. We're super grateful that Virginia stepped in and saved the day when our original speaker became unavailable. So Virginia, you already have lots of points on the scoreboard. Welcome, Virginia. Our international expert supporting dose reduction as the best pathway to stopping treatment is Professor Ehab Atallah from the USA. Now, I spent a week or so with Ehab climbing for a cure for CML in Nepal last year, and some of my very favorite memories are hanging out at the end of the walking train, debating some of the rights and wrongs of American politics with him. And I think that as an Australian, I held my own, but Professor Atallah demonstrated a willingness to defend the indefensible. So let's see what he brings to the floor today. Welcome, Ehab. It's a real honor to have you here. So there are opponents who reject the proposition. Our regional expert, Dr. Maria Soledad Undurraga Sutton from Chile, and our international expert, Professor Tim Hughes from Australia. And they will argue that a direct approach to TFR is the best pathway to stopping treatment. Soledad is an active contributor to the Foundation's work in Latin America, and her persuasive skills will be put to the test today, as I believe she might actually be a proponent for dose reduction as the best approach to stopping treatment, but somehow she ended up on the other side of the debate. So thank you so much, Soledad, for taking one for the team. I've seen Professor Hughes debating CML matters with Professor Jorge Cortez, and I can tell you he takes no prisoners. But he was conspicuous by his absence from the feisty debates about US politics with Ehab in Nepal. So I'm not sure what that tells you about his willingness to take on Ehab. Anyway, Tim, it's so lovely to have you here. A real privilege. Welcome. Okay, so let me tell you how the program will roll out today very quickly. We'll start with Virginia and Ehab talking in favor of dose reduction being the best pathway to TFR. Then Soledad and Tim will argue the direct approach is best. Then we'll invite rebuttals, questions, and comments, firstly between the experts, but we'll very quickly open up to all of you, the audience, to join in. So, Virginia, would you take the lead, please, by loading up your slides and telling us why dose reduction is the best pathway to treatment-free remission?
Okay, here we go. Thank you so much. It's such a privilege to be here with friends and colleagues that are passionate about CML as I am. And we're here with Professor Ehab to convince you that the dose reduction is the best way to TFR. So I'm going to share a case of mine, which I'm sure you will relate to because we all have these patients at the clinic. She's a 70-year-old female. She's perfectly fine, no relative comorbidities, excellent performance status. She's just running around. She's perfectly well. So she was diagnosed with CML at 2018, chronic phase, high-risk Polo, high-risk Hasberg. And I decided to go for dasatinib 100 milligrams a day. As you know, this dose is like the usual dose for the clinical trials, but we all know that these doses are way too high sometimes. But anyways, I wanted her to have the benefit sometimes to have TFR. So I started with 100 milligrams a day. She did well. She got a complete hematological remission by a month. 3 months, she will have less than 1% BCR, ABL, PCR. 6 months, she's having a deep molecular response. And she's in deep molecular response since January 2019, after just 1 year of treatment. So she was doing very well. And she started doing grade 4, 3-4 hematologic toxicity, basically anemia. She started developing anemia, which is not so common because she had been already a year in the medication. So I took a bone marrow biopsy. I did all the studies, and she kept going to anemia again. So I decided to switch her in June 2000. After fighting with this for 2 years, I decided to just switch her to imatinib in second line. She started imatinib on October, 400 milligrams a day. She was doing perfectly well. She was an undetectable disease. And then she got started doing intolerance. By this time, she was seeing that her PCRs were undetectable, and she had read about TFR. And she was insisting that she didn't want to take imatinib anymore. She was just 2 years, by now 3 years taking imatinib, 4 years, I mean. So I reduced the dose to 200 milligrams a day. She starts, she gets 200 milligrams a day for the whole year. I'm sorry, the first date, June 2024, 22 it's wrong. It's June 2020 that we're in the pandemic, and then October, which she changed to imatinib in October 2020. I mean, and then she got to dose reduction to 200 milligrams a day in January 2021. I'm sorry about the dates, but I messed up the dates. January 2022, she got a dose reduction. She was 2 years, the whole year in that dose. And her PCRs continue to be undetectable the whole year. So by now, we started in November 2018. She had been 3 years by now, in 2 years, excuse me, 2 years by now on TKIs. So she started telling me, I want to be out of this. I don't want to take it anymore. I've been undetectable for more than a year, and we reduced the dose and nothing happened. So she just convinced me. She was reluctant to take the medication. So we decided to do TFR. She just leave the drug. I did all the the monitoring as she was in a clinical trial every month a PCR, and then for the first 6 months, and then every 2 months. And she was without any medications, actually, from December 2020 to November 23, which is amazing. She was doing so fine. She was so happy without medication. Then she lost her molecular response in November last year, almost 3 years without medication. And then she lost her response. I waited until she lost his molecular response, and we restarted on imatinib. After 4 months, she was already in a molecular response, and I'm waiting for her last PCR, but I'm sure she's gonna be fine. So this a TFR has become an important goal in treatment-selected patients, those who achieve a very profound molecular response and sustain it for 2 years. But we all know that most of our patients won't get to that goal easily. Even for patients with optimal conditions, discontinuation will lead to losses of response around 50% of patients, leading to hypertension frustration. We all know when we do discontinuation, patients get really excited about don't having to have medication, and then 50% of them will lose the response, and they'll have to take the care again, and they get very, very frustrated. PKI doses are frequently reviewed in clinical practice. We do this all the time. What I did with my patient. We all the time, we know the dose we use is usually higher than it needed, and patients maintain the deep molecular response. Destiny trial is a UK phase 2 trial where they did what they did was they halved the doses for the patients on dasatinib, imatinib, or nilotinib for 1 year, and then after having the patients in the half of the dose, they discontinued patients. This is the first Destiny. The first report they did was the first part of the trial where they just doing half of the dose, and what they see is almost it's really the response is really low, even for patients that are only in molecular response. Only 19% of the patients lost the response, being in molecular response, and for those who were in deep molecular response, only 2% of them lost the response. So it's a very valid, in this first report, they show that it's valid to half the dose, and they saved like 46% of the budget. Then this is the second report where they reporting already what happened with patients after being in the half of the dose and then TFR. As you can see, patients in molecular response 4 group, which is the deeper response group, 67% completed the reservation time, and they were most of them, 72% of them were free of recurrence at 33 months, which is very, very good. And if you see that, it's better than any TFR trial we have seen. Even the group with the only major molecular response, 33% of them completed the whole study, and they were 36% of them were treatment free at 36 months, which is really, really surprising. There were no disease progression or recurrence regain molecular response within resumption of the treatment. And these results are really favorable comparable with discontinuation trials. So this is the curve of the STEAM trial. Of course, we all know this was a very strict trial, and most of those patients could be maybe continue to have discontinued without a TFR, if with a little more less stringent criteria. But even though all these are all the trials we have for discontinuation, as we can see, like most of them, 50%, around 50% of the patients lost their response with the discontinuation when we go directly to discontinuation. So this is my part. So this is the Ehab's part.
Thank you very much. I think that data from Destiny trial is really interesting. So I'll discuss some of the benefits of why we would go with a dose reduction first. So the things I can think of are less withdrawal syndrome, better immune control. We know that a lower dose in general has less adverse events and obviously decreased cost. Okay, so less withdrawal syndrome. In the Euroski trial, the withdrawal syndrome happened in about 30% of patients, and 1% of them had grade 3. The Destiny trial, where there was a dose reduction first before discontinuing, the withdrawal syndrome was only 21%, and no patients had a grade 3. In our discontinuation trial, in our discontinuation trial, there was we actually had 2 patients where patients immediately discontinued. We had 2 patients who needed to restart because of how bad the withdrawal syndrome was. I mean, I actually made it all the way to steroids and oxycodone, and then we had to restart their TKI because of how bad it was. So it seems, at least based on these numbers, that a dose reduction first leads to less withdrawal syndrome. The other theory is better immune control. So I will explain to you these equations very carefully. No, I'm kidding. No way. I don't even understand a thing about this. I just wanted to intimidate Tim Hughes, Professor Hughes. I'd like to see him put an equation like this up there. So it's very complicated. I tried to read the paper and understand it. I will not lie. It's some mathematical modeling. Dr. Fassoni, I don't know him personally. And they had this is their second paper discussing that we don't need a full dose. And here in this paper, they're also discussing if you have the patient on a lower dose, you're allowing for some immune control. And there's 2 theories to allowing, by using a lower dose, you're allowing for some immune control, is A, if there's any negative effect on the immune system, and B, this is their theory, is that if you allow for some BCR-ABL, maybe you'd be able to induce some T cells that would be able to get the patient to a deeper response. So a theory of a better immune control. We also know from this study, for example, that the dasatinib 50 is just as good as 100. Actually, in this paper, the dasatinib 50 milligram, when you started with 50 milligram, you actually did better than the 100 milligram. There's another paper by Philippe Russello of using doses, using the PK levels to use a lower dasatinib dose. So we know that a lower dose is safe. And this is the Dante study, where it's kind of almost similar to Destiny, where patients were on nilotinib. They had to be on, they had to have criteria, the same criteria for discontinuation. So if someone on nilotinib, they fit the criteria for discontinuation. There's a screening phase first to confirm, and then their dose is halved, is lowered to 300 milligrams. They stay at that lower dose for a year, and then you attempt to discontinue. And you can see the rates of TFR is 70%, which is really good. They reported in 2022 that 47 patients, at the end of the day, 7 lost DMR during that year, and 26 achieved and maintained TFR, which percentage-wise is closer to 70%, which is a really good number. So lowering the dose first, you could say it, for a better word, weeds out the patients that will not be able to maintain or achieve TFR. So you can earlier on lower the dose for those patients. You see their numbers go up, they cross 0.1%, you put them back on their drug again. So you're able to identify them faster, earlier, without actually taking them all the way off their drug. So what I also want to discuss or think about in general, should really our goal be treatment for remission, or should our goal really be decreasing the dose, period? Okay, next slide. So we all see these really nice slides of the decision of the rates of MR 4.5 or the rates of MR4 of 42%. ENEST-NZ reported 5 years. At 5 years, you have 60 or 70% of patients achieving MR4. However, when you look at decision, this is so deep into the paper, you can hardly see it. The previous slides that I showed you that looked really cool, that patients get to these really low levels, is not actually really accurate, because all of them was cumulative incidence. You hit that level one time, you're counted. But if you look at proportion of MR4 and MR4.5 at 5 years, not by, it's so silly, like that little difference there. It's only 40% for MR4 and only 25% for MR4.5. And these numbers are even lower for imatinib. And in the ENEST-NZ, I love the 10-year update, where they specifically looked at patients that would be eligible for TFR. At 10 years of nilotinib, 50% of patients, only 50% of patients are eligible to even try discontinuation. So someone in the next presentation might show you a curve that it's much higher than that, but these are the numbers from a large trial that shows that only 50% of patients actually achieve TFR eligibility. So is stopping TKI realistic? So if you have, so you start out with 10 people with CMS. Next slide, hit next. Half of them achieve that deep remission, and of the half that achieve remission, only 2 of them are able to maintain that. So at the end of the day, 10 to 20%, the successful TFR is only 20% of all patients. So in summary, decreasing the dose is better. We have a decreased cost for these patients for a time, better TFR rates, less withdrawal syndrome. From my personal experience, less anxiety. A lot of my patients, multiple patients tell me, oh, no, I don't want to stop. Let's reduce the dose for a year first and then stop. So it definitely reduces anxiety. And maybe, just maybe, our goal should be to reach the lowest effective dose first and have TFR as a secondary endpoint, because realistically, only 20% of patients will get there. If we focus on lowering the dose, and for some patients they achieve TFR, then well and good. I hand it over.
Well, that's the case for dose reduction being the best approach to stopping therapy. Thank you very much, Professor Ehab Atallah and Dr. Virginia. Okay, so let's hear what the opponents have to say about that then. Soledad, would you please load up your slides and tell us why the direct approach to TFR is the best way to stopping therapy?
Well, I hope I can make a good discussion with you. We are in favor of going directly to TFR. And well, why is this? There. Today we know the treatment goal is TFR. That is what we have been hearing the last years. And why? Because of long-term use of these TKIs means risk of many diseases, like especially cardiovascular events, arterial occlusive disease, like have been reported in with some TKIs like nilotinib and ponatinib, and we have pulmonary hypertension, like we have seen in with the dasatinib. And even though these are not very, very frequent, but they happen. And on the other hand, mild adverse events in some people, they really make their quality of life very low. Even small, just musculoskeletal pain or some fatigue or some edema, but you can tolerate that for maybe 1 day, but 2 days, but the whole life, that is quite difficult. So that's one of the main reasons why we our goal is going to TFR. And the high cost, of course, is another thing that we should never forget. And well, for our point of view, making the TFR directly, well, we have many studies, and many more than 3,000 people now there in these trials. And this slide is very confusing, but if I just made a small summary of the most, the most known ones, and the most the first one, STEAM study, that had 100 patients. And the thing is here that we have many trials. We have this about 20, 30 trials that are the most known, but they have many differences in their propositions, their goals, the design of the trial. But at the end, the conclusion is that almost all of them, we have at least around 50% of TFR with what we have today. But we know that these studies have made great contributions to going near to cure the disease someday. I'm sure that that will be the thing that we will have, because now we are starting with all this of the immune system that I think I've always thought that it's the most important in TFR. So all these studies have done this treatment-free revision, and they have shown us how we should move on with our patients. As we can see, the Twister trial in Australia had a 42.7% of TFR at least at 3 years. But now the trial has been more than 7 years, and we know that in many other trials that's very similar, the proportion. Here we have the Twister was with imatinib, and the daddy from Japan, it is with a TFR with dasatinib. And here we see that even though dasatinib is a second-line TKI, second generation TKI, we see that at 6 months, almost 49% of the patients had lost their MMR. And we also know now that there are some late patients that lose their MMR. And also we have learned that it's very different when patients have been intolerant to the one drug, and very different to the patients who have been resistant. The patients who have been resistant, they have a very low TFR. On the contrary, the patients with intolerance have done quite better. And in the top second generation TKI trial in France, they taught, this trial has taught us that these patients have a lot of fluctuation, and that most of them, almost 85% of the patients, relapse in the first 6 months. We have maybe 15% in the rest of the year, but there are also late relapses. And well, all these clues that are being given by these trials are very important for the future of the ongoing investigations. And all these trials have shown us and have suggested the optimal criteria for the selection of TFR as a treatment goal. And we know that SOCAL score, as we have seen, shouldn't, at least the lower the SOCAL score, the best the results. And these have been shown in the steamer and the twister. The typical transcript, BCR-ABL transcript at diagnosis, is very important. And we know that in some cases, there are patients that don't have the typical transcript, and it's very difficult to follow those patients. The past history of CML, we know that chronic phase does better than patients in accelerated or plastic phase, of course. And the stop second generation TKI also showed us that response to first line TKI therapy is optimal if there is no previous resistance. It's better for TFR. And the other issue that was mentioned, been mentioned before also by Virginia, the duration of TKI therapy. The longer, the better. More than 8 years, it seems that it's a good number, at least for what we have today. And also the depth of molecular response. At least we should stick to 4.5, MR 4.5 or more with undetectable MRD. The lowest you go with the response, that means that you're getting to a zone where your immune system maybe can fight the disease. And so to make this TFR also, we know that we have learned that at least it's better if you have a longer duration of a deep molecular response. And if also the patient has had a good treatment and with a early molecular response. And that is also, that happens mostly in low risk patients. And one thing that we can't forget is that we need a close monitoring of the patients, at least monthly for the first 6 months, so that we can detect early if there is a relapse and we can start treatment again, and so there is no risk for the patient. This is a very important issue in our countries because it's not everybody has this molecular monitoring and standardized, and so there are very few labs, and they cannot assume this new, more samples for the lab. So this has been something difficult for us of doing TFR because of the lab that we don't have those many labs. Well, I want to share a case with you with a 7-year-old woman. She was had hypertension, high cholesterol, but was well controlled. Her diagnosis was 207 with a so-called intermediate and a P210. She started on imatinib for 400 milligrams, but at the first month she had to stop imatinib because of a grade 3 gastrointestinal adverse event. So we couldn't go on with imatinib, and we switched to dasatinib. It was at those times we used the 100 milligrams once a day, and she was well tolerated. She had an optimal response and MMR at a year and MR4 at 24 months. But 5 years later, she had a pleural effusion, and we had to stop dasatinib. The pleural effusion was not very heavy, and it was very rapidly resolved. She refused to start nilotinib, that was the other drug that we had at that time. And as she had been monitored molecularly every 3 months since diagnosis, she decided to try TFR. And we said yes, it was the only option. She was monitored monthly, and at the 3rd month, she lost MMR. So the only thing we could do was restart the dasatinib, but this time we restarted at 50 milligrams dose, and she regained MMR at 5 months, and she has been fluctuating between MMR and MR4, and she is, even though she is very old today, but she is still alive and has very little side effects. So maybe we should try to stop again. I don't know, but that is the case. So Tim, it's your turn.
Yeah, thanks very much, Soledad. So I think I've been sabotaged here because I've got 3 true believers in reduced dose. I'm the only one that actually believes in classical TFR. Even the case you gave was probably an argument against TFR, Soledad. So anyway, let's focus on the data we know about from Euroski, where very clearly these chances of success are related to the duration of the therapy and the duration of the deep response. And that suggests to me a model where you get a steady reduction in leukemia with the TKI therapy. You get into a deep response, which is shown there in green. And then at some stage, at some point, you cross a line where there's no longer any leukemic progenitors that are capable of relapse. And unfortunately, we don't have sufficient handle on the biology today to know when we cross that line. Right, so you get to a point, which is what I'd say is the point of no return. At that point, and beyond that point, whatever you do, start therapy, reduce therapy, stop therapy, the result's going to be the same. There's no chances of recurrence of the disease. So if you have an attempt at stopping, and you don't know whether they've crossed that point yet, but if you happen to try stopping, they've had 3 years of deep response, you know that they're eligible according to the classical criteria. If you stop at that point, what's going to happen? Well, yeah, they're going to relapse quickly. And it doesn't matter whether you go to a half dose or whatever you do, it's not going to be successful at that time point. So, but if you go beyond that time point, it doesn't matter whether you stop or whether you reduce dose, the result's going to be the same. It's going to be successful. So that's a sort of a black and white interpretation of TFR. We can argue about whether that's too simple, but so what are the arguments in favor? Well, I think we've heard those. Patients may feel more comfortable. I think that's all about how you talk to the patient. I talk to the patient about the risk of stopping being about the same as the risk of continuing. So it's not a matter of leaping into the unknown. It's a matter of weighing up the 2 possible options and saying, well, maybe it's now a chance to find out whether I still need my drug or not, or whether I've passed that point of no return. Secondly, less withdrawal syndrome. If you dose reduce first, maybe the data is not that convincing. 1% incidence of grade 3, you wouldn't even see that in a study of 80 patients. So I don't think we really have a convincing evidence of an improvement in withdrawal syndrome. We need more data. Recognize patients who shouldn't stop before stopping. That is it an advantage to halve the dose, have the patient lose their response, and then go to full dose versus stopping, having them lose response, then going back to therapy? To me, it's not really a clear advantage. In either case, they're showing evidence that they need the full dose of drug, and you're going back on the full dose of drug. I think probably the most convincing argument is maybe we're improving the chance of success by going to a half dose. I mean, Ehab showed some very convincing modeling, which he beautifully presented, which is really persuasive that the immune system is critical. But you know what? I don't think we really know. And I think we're entirely speculating as to whether the immune system is critical or not. We know that some immune markers at the time of stopping are very predictive of success. But we don't know whether that means that the immune system needs to be active after stopping, or whether those markers represent what's happened over the last 3 to 4 years. They're more an evidence of what's been achieved rather than what is about to be achieved. So I think that's still a very open question. The reality is we don't have any randomized studies, so we don't have a rational way to compare these 2 therapies except by semi-rational argument. Now, Ehab spent most of his time trying to convince us that TFR is futile anyway, so it doesn't matter whether you dose reduce or stop. You shouldn't bother. You should just try and get the dose right and keep the patient comfortable. I would say that's not the case, but let's go through the arguments in favor of TFR. First of all, we have more than 15 years experience. Soledad showed the twister data at 7 years. That was published in 2013. We now have another 11 years. None of those patients have relapsed. It's incredibly stable. It's incredibly safe. And we don't have that data with slow withdrawal and cessation. We don't have that at all. We have 2 studies. We have Destiny and Dante, sort of 75 or 80 patients. So it's a very small data set to be saying this should now be our standard of therapy. We need to study it in the clinical trial setting. We need to compare it head to head with TFR. But at this stage, it's very much an experimental approach, which is interesting and needs further investigation. But we have no idea about its safety and about its long-term efficacy. And as I've tried to point out, if you haven't reached that point of no return, then slow withdrawal just delays the time when you can actually identify that the patient needs their drug again, and therefore delays any attempt at second TFR, which we know increasingly is becoming successful. We have a success rate in the second attempt of about 40%, but you have to wait several years before you can attempt to try a second time. So I think if you're truly over that point of no return, and we wish we had good markers to identify that, we don't. But there's nothing to be gained by going to a half dose if really you no longer need your drug. And of course, the other issue is that going to half dose for 12 months, you're exposing the leukemia to a half dose of effective drug. And in the laboratory, we know that's the perfect setting to induce resistance. That's how we develop drug-resistant cell lines. We give them low dose and then slowly increase it and get more and more resistant clones. So who knows what's going to come out in these patients over the longer term? We don't know. It's an entirely experimental approach at this stage. So that's what I'm telling you. There's no point just creeping into the cold water. That's painful. Jump in. Just do it. If the patient is eligible, just do it and find out whether they don't need their drug or whether they do need their drug, and stop mucking about. Thank you.
Thank you very much, Tim and Soledad. Some very powerful arguments there. And thank you before them, Virginia and Ehab. Okay, so having heard both sides of the argument, Ehab and Virginia, would you like to start with some rebuttals, some questions, some points of discussion? And then Tim and Soledad can have a right of reply, and then we'll, and then we'll open up to all of the audience. Virginia and Ehab.
Ehab, go ahead, please.
Of course, excellent argument. We knew we were up against Tim Hughes. So the only argument I would make is we know in terms of the low dose is that in terms of developing resistant clones, we know that that doesn't really happen, because like with low dose, we know from the Red study, the dose reduction, the dasatinib 50, we know that the resistant clones don't develop. We also know that when nilotinib specifically was developed, which I wasn't around at that point, it was developed as like twice a day, a really high dose. And we know that with once a day, it was already beyond therapeutic levels for specifically nilotinib. PK was once a day, and the choice was to keep going up. I think that would be my only rebuttals regarding the low dose being a not safe approach.
If I can I counter that? Is that part of the rules? I haven't got gloves, but I mean, what's your argument there, Ehab, is that we're using nilotinib at too high a dose, and probably we are, and bringing it down to a half dose is probably a therapeutic dose. That's not an argument for using a half effective dose, which is what we do probably with imatinib. When we go from 400 to 200, we are literally going from inhibiting BCR-ABL to partially inhibiting BCR-ABL. And that's what worries me. And that's where I think long-term data needs to be seen. And even in the OPTIC study, where they halved the dose of ponatinib once patients achieved a 1% or below, they saw in some settings that 30 or 40% did lose response, and some of those patients didn't regain response when they went to higher dose. So I think we need to be careful about halving dose is perfectly reasonable in the setting of nilotinib and dasatinib, where in fact you're still using a therapeutic dose. But I'm much more concerned about using a half dose of imatinib. 200 milligrams, it's almost teasing the leukemia to find something to fight back.
Well,
Virginia and Soledad.
Well, it's hard to debate with Tim Hughes, first of
Yeah.
all. Okay, but my point is, I think, and he have also told us, is that actually very few patients go to TFR in the real life. You know, most of our patients won't go there. I don't think it's gonna be a thing about one or another. I think there's going to be patients for TFR, and there's going to be patients in which we can have the dose. I don't really think it's really a debate. I was defending lower dose, but I didn't. I really think, as you do, that if you have a patient that's really ready for TFR, just try it. You know, but there's in the real world, there's going to be a lot of patients that can be have a good response with lower doses, and that's what I think is really the discussion and where we should go, because there's TFR is only going to be a reality for a minority of patients. So we should try to. I show it in my patient. You know, I was trying to get her to TFR, but 100 milligrams of dasatinib is way too much, and then she won't tolerate it. And so what we need to know is that we can find lower doses with good responses, again.
Well, I think that, let me see what my arguments could be. Well, I'm convinced that TFR is a real need. I think that we have gone a lot farther than what we thought at the beginning. Remember that at the beginning, when the years 2020, 2022, or until 2000, year 2000, 2005, 2007, when we put a patient on a TKI, we insisted that this is something that you will have to have for life. So get used to it, it's forever. And after a few years, we started to tell them, well, we could try to stop treatment now. So it was very difficult at the beginning, because they were very, very scared about leaving this treatment that was supposed to be for life. But we have learned a lot, and I think that we shall go on learning, and that at least in this way, in the TFR, direct TFR, we have so much experience, but we need to follow up those patients longer and to study those patients that are in TFR, that we know that if we have a very sensitive techniques, I'm sure we will find the fee there. But somehow our immune system, I think, will be able to control it, as it happens every day in our lives with the cells that are mutating. So I think it is very important to follow these studies, so that we and these people and the investigation in these people that are in TFR, and the others also, to really find out which is the point, what shall we do, which is best for our patients. So I agree with Tim that if we have a patient, we have to just go for it, and put more patients in this TFR, so that we can learn much more. There's so little experience with lowering dose, even though in a trial, but many times we do that because we needed to do it. So, but there's very little experience, and Ehab also say, well, this is a theory. So there's no theory based on such few number of patients. Don't you think so?
At this point, there's lots of there are lots of comments coming through, and I'm not going to be able to keep up with them. The first one there is from Ana Inés Prado. Would you like to ask your question? Remember, you can use whichever language you're comfortable in. And Inés, would you like to ask, or would you prefer I read it?
Sí, buenas noches para todos. Yo les quería plantear una paciente joven de 50 años que tiene una leucemia mieloide crónica que cumple todos los criterios para discontinuar el tratamiento, pero que al diagnóstico en el cariotipo tenía una deleción 17Q, que la paciente logró la remisión citogenética completa a los 6 meses y la alteración desapareció al año de tratamiento. Ya lleva 8 años en una respuesta molecular profunda, pero realmente no me animo mucho a discontinuarle y quería preguntarle la opinión a los expertos.
Perdón, ¿17Q o 17P?
17P menos, perdón, gracias Soledad.
Who wants to answer? Ana.
I'm always super cautious about patients who've got worrying signs at diagnosis. 17Q minus is a worrying sign at diagnosis. I'm also worried that she took 12 months to actually, but it sounds from that as though she still had detective pH positive cells at 12 months, which is not a fantastic response at that stage. I'd like it to be deeper. Having said that, she's got MR 4.5 for 8 years, so that's a pretty conservative place. I think I discuss it with her in terms of there is an added risk involved here because we don't have a lot of experience with patients with this sort of higher risk abnormality of diagnosis. And it would depend a bit on how much she's suffering in terms of side effects. I don't know what drug she's on. If it's imatinib and she's tolerating it beautifully, then I'd be less motivated to stop. If she was on a more toxic drug to maintain that response, then I might be more keen. And if she had side effects, I might be more keen. So it's not a black and white situation. There's a slight concern about the 17Q minus. It's not a complete contraindication though. And I just tend to be more conservative and more driven by her motivation and her level of side effects.
Yes,
Any other comments on this case?
I would say that
La paciente, les comento que la paciente está con imatinib y en realidad lo tolera bien. En realidad ella tiene la inquietud de en algún momento poder suspender el tratamiento, pero tampoco es algo que esté demasiado motivada y tolera bien el tratamiento. Yo creo que sí, que me parece que la voy a mantener en tratamiento y si surge alguna toxicidad, bueno, reevaluaremos.
sí, yo creo, Ana Inés, lo que te quería decir es que si tiene, digamos, la alteración que tenía, una alteración citogenética, digamos, importante, porque en el fondo involucra el TP53, y sabemos que esa es lo peor que le puede pasar a nadie, y solamente con los inhibidores de ITK yo pienso que te va a recaer, podría recaer, digamos, tiene altas posibilidades. Y si es tal como dice Tim, que no tiene mayores efectos secundarios y sobre todo que es imatinib, que lo puede tolerar bien, por último yo esperaría un par de años más y además esperar lo que nos dicen las nuevas investigaciones, que de aquí yo creo que a un año ya vamos a tener resultados. Eso.
I don't know whether you agree with me or disagreed.
Sí, estoy de acuerdo con
she
el
agreed,
profesor Hughes.
We might move on to a question from Diana Cuervo. I'll read this one just to move us on. What are your thoughts on reducing dose in a patient who, after going direct TFR and losing response and restarting the same TKI and reaching MMR 4.5 after a certain time?
Question for Ehab.
I think would depend on the TKI, like Tim suggested, like the satinibide and nilotinib, I feel very comfortable reducing. Imatinib, I would hesitate less than 300. Bosutinib, 300 to 400. So it really depends on the TKI that you decide to restart of what they're on. But I would attempt reducing for sure.
Yeah.
It makes even with imatinib, like even that little 400 to 300. I don't know what you all think, but even that little 400 to 300 makes a huge difference in the patient's quality of life.
Yeah, I find that the initial phase, my patients are really motivated in most cases to get to TFR, and they're willing to put up with a certain level of side effects on their therapy to maintain that deep response so they're eligible. And then they try, and of course, half of them succeed, half of them don't succeed. And at that point, it's much less emphasis than on thinking about second TFR. It's still a vague possibility, but much more focus on, well, let's find the drug and the dose that you're comfortable with that we can keep you in the longer term. But that's the sort of approach I would take in someone who has had a clear, particularly if they've failed very quickly. Because if they fail quickly, the chances of success for the second TFR are pretty poor at the moment, unless we don't know how to do that. So I very much focus on getting those patients to a comfortable dose, because it might be for the rest of their lives. But while I'm quite hopeful that we can get our rates of TFR up to over 50% over the next decade, I don't think we should forget the fact that there are patients, as Ehab's pointed out, that are not going to get there, even with the best therapy today and tomorrow. And we need to have a strategy for those patients.
Virginia, do you have a comment?
No, not at this point. But I think I wanted to ask Tim Hughes or Hematologic, what do you think about those patients that lose TFR and they really want to try again? Would you change TKI to intend a second attempt?
Well, we not always. If the patient's fragile and has cardiovascular issues, we're not going to throw them on nilotinib and take that sort of risk, because the chances are still fairly remote of a TFR2. But for the patients who are younger and maybe have had, for instance, a patient who's had 5 or more years of nilotinib to get to their first TFR and has stopped and not been successful, I might put them back on nilotinib straight away, because I know that they can tolerate it, and get them back to a safe place. But then I'd talk to them about maybe low dose dasatinib, something which has got a longer term safety profile, because I'm very much reluctant to use nilotinib beyond about 5 years, given the cardiovascular risk profile. So in that situation, I'm thinking about long-term safety issues, and I might switch for that particular reason. Would I go to if the patient was on imatinib, would I increase the intensity of therapy to try and get to a second TFR? Well, we don't have a lot of data about that yet. We have the Canadian study, which tried that approach. It wasn't successful at all, but they tried their second TFR very soon after the first TFR, within about 1 to 2 years. And I think that's probably a mistake. You need to be much more patient to get to a second TFR. So there would be patients where I'd switch from imatinib to a modified dose dasatinib in that setting, but I wouldn't. I'd certainly give them at least 3 or 4 years before I'd try for a second TFR.
Well, as Tim says, I quite agree with you. And the thing is that all the decisions that we take patient to patient, it's patient to patient. Really, we cannot make a general recommendation, because every patient is different comorbidities, different adverse events, different everything. So we have to take patient to patient and study that patient and see what's best for him. And that's the real world.
I agree, and we also have a couple of clinical trials of adding ruxolitinib or adding asciminib for second TFR attempts for a year. And when we opened those studies, we thought accrual would be really fast. Surprisingly, accrual has been very slow. We think patients, after attempting the first time, they're hesitant. Patients are hesitant to add another drug that would add side effects. So it's been a challenge to accrue to these second TFR studies, which honestly is kind of still surprising to me.
So there's a comment from Virgilio Salinas that you may want to pick up on. New genetic alterations may be the cause of not achieving MMR and having TFR success. You may want to pick up on that.
Yeah, I mean, there's evidence that that's the case, but it's still sort of certainly having an impact on molecular response. I don't know about impact on success of TFR, but actually there is a study, from Satu Masjuki's group that suggests that those changes do reduce the chance of success with TFR. So I think it's going to become increasingly important to know the genomic profile of the patient at diagnosis.
Yes.
Am I allowed to ask a question? Like I guess I am asking it. Who does the E14 versus the E13? I mean, I personally, my lab does not differentiate, does not tell me if it's an E14 or E13. I think the data is pretty convincing as far as I can tell. What are your thoughts on that?
It's about a 10% higher chance for the patients with the longer transcript, the E14A2, for unknown reasons. So it's a real phenomenon. It's been validated in several studies now. We do it at, our PCR is actually gives us either, it gives us both measured, and you can add them up if they have both. So we always know whether they have the longer or the shorter of the two standard transcripts. Doesn't have a big impact on the decision, though, to be honest. I mean, is it 50% chance or 60% chance? Does that change anything? I don't know. Maybe subconsciously it makes me wait a little bit longer in the patients with the E13A2. But anyway, it did come out in our study as well. And so it's not nearly as strong as halving time, which I still emphasize is incredibly important. That the rapidity of the reduction over the first 3 months of therapy is incredibly predictive of success of TFR. Much more valuable than the transcript type, but it's also needs to be measured accurately.
Just a comment. I think in most Latin American countries, we cannot measure like atypical variants.
Atypical variants? Yeah, we all have problems with those.
Yeah.
Luckily, they're rare, 1 or 2 or 3% maybe. But that's a challenge that we haven't got easy answers for that at the moment.
Beatriz Moiragui is asking from Buenos Aires. Hi, Beatriz. Nice to see you here. She's asking if you have experience with TFR in the copies.
Oh, generics.
Generics, yes.
I don't, but I can't see why it'd be any different.
Yeah, I mean, I do have, imatinib is generic. I have not quantified it, but I do have experience, and I haven't quantified it in a study, but clinically there's no difference.
Yeah, in Colombia, we also have imatinib, and that's been generics for a long time. And we've done TFR on generics also. It doesn't seem to be different. And Bea is saying that in Brazilian trials, it looks the same. Yeah, I think it's like the same.
Can I ask Katia Pagnano? Katia, you always have good stuff to say, and you're commenting in the chat. Can I invite you to speak, and we'll maybe have Katia, sponsors from our experts, and then perhaps wrap it up. How does that sound?
That's good.
Hi, everybody. I'm a little bit sick today. I got a terrible cold in the Ehab Congress. But what I would like to ask you, congratulations about the presentation. Tim, did you see that Chinese paper that showed the randomized trial? I'd like you to hear a comment about that.
Yeah, well, I sort of vaguely remember it was happening. I can't remember seeing the final results. Do you have it there, or?
As I can't remember the journal,
trial.
but I saw it recently, and it was showed a higher curve for the group that was randomized to the de-escalation before discontinuation. I was very.
I knew it, Katia. I knew I was right.
That's unfair. That's unfair.
Sabotaged again, I think. Can you send it around, Cardia? Because I haven't seen it.
Yes, I will
I
send
haven't
you
seen it
after
either.
Yes,
after we're done
please,
here.
you have it.
We were
Yeah, I
saving
was
that
saying.
for the last time. Kat
Yeah,
is
Okay.
always.
Just
Okay.
to completely destroy my arguments.
That was the dessert.
No, I was want to hear your opinion about that.
That was nothing to do with me.
Well, that
I'd like to
was
see the data.
Sorry?
I'd like to see the data.
No, I was saying this to you, Tim. Okay, but
Okay, so maybe we can have some final comments, please, from Tim, Ehab, Soledad, and Virginia.
I guess my comment would be very much, I still think that TFR is something that we should be aiming for and continuing to push that number up. I mean, in Adelaide, we're following the cumulative incidence of TFR over many years, and now up to about 20 years. And at 15 years, it's up to 40%. I know it's a long time to wait, but it's not 10%, it's not 20%, it's 40%. And that means there's another 40% who tried and didn't succeed. And increasingly, we're getting those patients to a second TFR and getting about a 40% success. So I think we need to be aiming to push that number over 50%. I'm not one of those that argue, and I know that there are many, that TFRs are sort of a peculiarity on the side, and we should be focusing on managing our majority patients in terms of their side effects rather than fiddling around with TFR. I'm very much on the feeling that we should be doing everything we can, particularly with the new agents we have available, to push that number so it becomes a majority expectation, whether it be by a slow reduction first or a sudden stop. That I'm open to argument.
I agree with you, Tim. And I think that what we should aim also to go to that goal, to get to there, is to have better studied our patients at the start, like the genetic profile, the molecular at the start. And if they are not doing well, we need to have our standard studies to have the molecular in these patients so that we can treat them knowing better what we are doing.
Yeah, I completely agree with you, with all of you. I'm really a believer in TFR. And I think TFR has brought something else to us, is that once we're aiming to do TFR, people is doing a lot more monitoring, a lot more, being better in treating patients. I think we were very, very relaxed before, not us, that we are, like nerds and CML nerds, but I mean, for the real community, people didn't care about monitoring because they're gonna, go on forever with these drugs. Now that we're thinking about TFR or reduction of the dose, whichever we would do, people is taking more care about monitoring in the right way and trying to do the right dose and all that. And I think that's something else that TFR has brought, and once you start doing TFR, you want to do it, once you succeed in that, you would want to do it. So I'm sure people would do it. And I think, as I said, my comment is that we can do both. We should try to minimize adverse events in these patients as much as we can, doing TFR or reduction of the dose.
I also wanted to add before Ehab, it is very important to go on monitoring really like frequent, like every 3 months at least, because that is the instance in which we can teach the patients and keep them pushing on and taking the drug, even if they and speaking with them so that we get to know better what they are feeling. So that was my message.
Yeah, absolutely. And that's been shown in studies, is like the frequent monitoring actually leads to better adherence. And I agree, we need to continue to follow both and try to reduce side effects, stop drug. And I personally have written that in papers of, if your goal in patients is TFR or if your goal is not TFR, I personally think TFR should be a goal of all patients, the older I get. the older I think, because a lot is like, oh, if you're older, you don't need to get to TFR. I'm like, no, even no matter what your age is, your goal should still be TFR. So thank you very much.
And unsurprisingly, Professor Ehab Atallah managed to get the last word.
Yes. As usual.
That was so good, and thank you everyone for your patience and hanging in there as we went a bit over time. This is the first time we've used simultaneous translation, and that was a great experience for me. Really great to see how that worked, and it was worth a bit of additional time at the beginning till we got into it. Thank you so much. Thank you, Professor Ehab Atallah, Professor Tim Hughes, Dr. Soledad Undurraga, and Dr. Virginia Abello Polo. To those of you who put questions into the chat today, if they didn't get answered, I'll try to get back to you. If you have any other questions or issues about dose reduction or TFR, please get in touch. As you can see, we're very well connected. If you ask a question, we will find you an answer. So just very briefly at the end, we hope to see you again soon. The next Latin American discussion will be on Thursday, the 8th of August, same time as today. Have a look at those presenters. It's going to be a great discussion. Please join us for us. Third meeting, we go back to the laboratory and ask how to get the best out of it when resources are limited. It'll be a great discussion. And we hope to see you live. We hope to see you online too. If you aren't already familiar with the ICMLF Knowledge Center, please go check it out. It's a wealth of knowledge. There are lots of dedicated modules, and you can see a major new module, Next Steps in CL Management, under development and soon to be released. If you want to keep up to date on what's new in CML, check out our website, sign up for the newsletter. We'll send you Tim's papers of the month, keep you up to date with upcoming meetings, webinars, links to summaries of conferences or discussions. You can also engage with our interactive case discussion forum, where we take difficult or interesting cases to the key experts in the world for advice or for commentary. Please use it. It's a resource that's there for you. Or you might prefer to engage with us in social media, Facebook, Instagram, X, formerly known as Twitter, whatever it is that you like to engage with. Okay, that's it from me. Thank you, gracias y obrigado, and hope to see you again on August the 8th. And thanks so much, guys, for a great debate. That was so fun.
Awesome.